Waiting another moment or so for 7 o'clock Eastern, and then we'll get started right away. You probably another 30 seconds. And for those of you in the audience, please feel free during the webinar if you have any questions to submit those through the question and answer icon on your screen, and we'll do our best to answer those live. Just give it another few seconds and then we'll get started. Like a few more have just joined, so I'm going to give it another few seconds. All right, well, I have 7 o'clock Eastern time, so I think we'll just go ahead and get started out of respect for everybody's time. So welcome to AIM at Skin Cancer's webinar series, a closer look at skin cancer. And for those of you that don't know me, I am Krista Rubin, nurse practitioner and AIM at Skin Cancer's Ask a Skin Cancer Nurse. For those of you who are joining the webinar and are not familiar with our organization, AIM at Skin Cancer is a foundation dedicated to raising awareness and providing support for those affected by cancer, both personally and family members or other loved ones. And through this webinar series, we have designed it so it's a way to explore a comprehensive array of topics surrounding skin cancer treatment, the emotional aspects, caregiver issues, for all of those affected. And I want to thank each and every one of you for joining us because it's commendable that you're doing all that you can to learn more about skin cancer. So tonight we have a very interesting topic, I think. The title of tonight's topic is Emotional Impact from Skin Cancer Surgery. And I'm thrilled to have this discussion with Dr. Oliver Wisco. Dr. Wisco is an associate professor of dermatology at Brown University in Providence, Rhode Island. He's dual board certified in dermatology and Mohs micrographic dermatologic surgery. He serves as director of the Brown Dermatology Cutaneous Oncology Program and the chair of the department's Quality and Safety Committee. He is also director and founder of the Brown University Healthcare Institute Center for Performance Measurement, which focuses on developing strategies to enhance healthcare quality, optimize clinical workflows, and improve patient outcomes. In addition, Dr. Wisco serves on the academic faculty for Brown's Master's in Health Informatics program, where he contributes his expertise in clinical information and health systems innovation. Dr. Wisco is also the founder of Dermatology Health Specialists, a clinic system focused on providing dermatologic care to high-risk and underserved population. Geez, I don't know how you find time to do anything. So I'm thrilled to have you join us. I think this will be a very interesting discussion. So I appreciate your time. Welcome.
Absolutely. Thanks for having me, Krista. It's a pleasure to be here. I echo your comments about the admiration for those that are joining today. Skin cancer is such a critical issue, and it's very important to get these messages out. So thanks for having me.
Great. Glad you're here. All right, so we know that the number of skin cancer diagnoses in the US is staggering and just increasing for a variety of reasons. That's beyond our topic tonight, but the majority are non-melanoma skin cancers, and that's really what we're going to focus on tonight. And fortunately, most skin cancers, when caught early, are incredibly treatable and for the most part curable. And generally that occurs through some type of surgical procedure, right? So like some type of scraping and burning or some type of surgery. We also know that those surgeries leave scars, not just physical scars, but emotional scars. And it's really challenging for many people to deal with the consequences of a dermatologic surgery. It's one of probably the only cancer that it's on the outside, where many other cancer surgeries or most surgeries for anything else are all on the inside and can be hidden. But you can't do that with skin cancer surgery. So, as a skin cancer surgeon, one question, or I've given this a lot of thought because this is not always an easy topic. As a physician, do you think about the emotional impact of the surgery that you're recommending when you're seeing patients? And I say that with the utmost respect because your job as the physician is to make sure they're getting the appropriate treatment. But that nurse in me, of course, is thinking this can be devastating, a devastating diagnosis for so many. So, how do you merge those two concepts?
Yeah, it's a tough balance, right? We take care of people um as our number one priority, right? And then unfortunately, patients and people will come with disease processes that we have to address. And from that perspective, we have cancers, and that diagnosis can be so overwhelming to patients. And so I like to think about it a slightly different way as a skin cancer specialist. And I think this next generation of skin cancer specialists that are coming about are being much more mindful because our
Mm.
training is now not just a procedure, it's much more a procedure as part of a treatment approach to a larger patient population. So our skin cancer fellowships, which used to be called Mohs surgical fellowships, are now called micrographic surgery and dermatologic oncology fellowships for
That's a
specific,
mouthful.
yeah, MSDO fellowships for exactly what you're addressing. We're taking care of people, and we have to be more mindful than just thinking about it as a cancer that we're removing. So everything from taking a more holistic approach and also thinking about skin cancer slightly different. We have melanoma, right? Which melanoma, for the most part, argued with the earlier stage melanoma in situ, is can be a very deadly disease and should truly be treated as a cancerous process. But there's been newer data that's shown that because basal cell and squamous cell carcinomas, the part of the non-melanoma skin cancers more recently called keratinocyte carcinomas, which is the more frequent types, you can kind of think about it as a little bit different. Definitely when they get larger, more aggressive, you think about the true cancers process. But when they're smaller and more widespread, you can think about it as more of a chronic disease process. And you think about the skin as a larger organ system. So the process of thinking about a patient, and as I start addressing them, I start talking to them about this long-term process and how my ultimate goal is obviously there's something we need to address now, but is there a way that we can take it from a different perspective of let's try to minimize the disease, the damage it's had over the years. And the reality is most of us have not had the opportunity to think about prevention because many of us, when we were younger, it was encouraged to be outside. It was encouraged to get sun damage. And let's just face it, skin cancer very much is a disease of healthier people, right? Because you get disease from the sun because you're outdoor more often, whether it be your job or recreation. And we see more healthier people with less other comorbidities getting skin cancer simply because they're out and being healthy. And reality is if you're not outside and you're never getting exposed to sun, and obviously we protect ourselves as much as we can, um, we'll be inside, we'll get less exercise, and then we'll die of other disease processes rather than skin cancer. So there's this interesting balance. So taking this more global approach and thinking about the scarring that can happen with this cancer, I really like to take it from a different perspective of saying, look, this is an unfortunate thing that you had. The reality is it's not necessarily your fault. There's some circumstances that led to this, and let's start talking about prevention at the same time. Let's start talking about the surgery and what potentially could be the long-term outcomes. Everything from the scar, but more importantly, let's also equally talk about at the same time preventing this down the road. And then obviously from there, I take it from the approach. And once again, making sure that they understand I'm thinking about them, not just the procedure we're about to do. I then talk about the guidelines. I always go into the National Comprehensive Cancer Network guidelines. Anytime anybody ever talks about cancer, we go into the guidelines. And from there, then we talk about the options. Obviously, as a skin cancer specialist that's trained in Mohs surgery, usually by the time you get to me, if we're going to be cutting out a basal cell or squamous cell carcinoma that's on the head and neck or other vital locations, usually you're there to see me for Mohs surgery. But I'm going to go over all the other options with you. And there are other options. But at the same time, there are very clear treatment algorithmic recommendations that are data-based that says this will give you the best outcome. And in theory, the least amount of complications, whether it be recurrence or scarring or infection down the road. So I think about the complications as a global approach, but I also think about the ramifications of the other treatment processes that we will likely be discussing, knowing that sometimes scars are better than a much larger scar if a recurrence happens with a treatment that will give less or a lower cure rate.
Okay, so that was quite a mouthful. And you gave a tremendous amount of information, which I think is incredibly helpful. Couple points I want to just go back and touch upon just to clarify for the audience. So for those of you joining us tonight that may not know what Mohs micrographic surgery is, that is a particular type of surgery by a specially trained dermatologic surgeon. And basically the cancer is removed layer by layer and looked at under the microscope. And so the removal, the amount of tissue or skin removed is only enough to get out that cancer, as opposed to just kind of going in and doing what's called an excision, where they remove skin and hope after that all of it is cleared. And this is very specialized because many of the skin cancers are on the head and neck. And so we don't have a lot of skin to play around with on those areas. Did I miss any point? Do you want to supplement with anything about Mohs? Just
Yeah,
basic.
that's great. The real estate is expensive up here, right? So we want to make sure we minimize the amount of damage in those areas. And to your point, when we think about surgical procedures, we think about it from the perspective of margin control. And so sometimes you're in a place where there's less vital structures that we have to deal with. So if you're dealing with the back versus the tip of the nose, obviously larger margins is not a good idea on the nose, but you can get a clear margin with larger margins on the back and get away with it and be okay with it.
All right, so
Versus the
let's talk
nose,
about that. If I can
yeah.
interrupt you, and I don't mean to, but let's talk about margins. What does that mean and why is it so important? Because really that's foundational to your recommendations.
Yeah, absolutely. So thank you for clarifying. So if you think about it, we have the cancer that we can see with our eye, and we think about it in a few different ways. We visualize what we see, what's in front of us. We actually scrape it, and then we identify how big it is tactily. And then what we do is we identify the extent of it histologically. And
Meaning,
so what it
explain
looks like
histologically.
histologically, what it means underneath the microscope. And what we're doing underneath the microscope is we're essentially looking at the tumor at 1/1000th of a millimeter. So pretty small. And what we literally want is 2 cells thick clearance when we're dealing with a basal cell or a squamous cell carcinoma, which are tumors in theory that most of the time will grow contiguously, which means it'll spread out together. Versus there's some cancers that will grow, but then they'll have cells that jump. Obviously, if you're trying to do a procedure in which you're tracking it in a very narrow margin, it needs to be contained. But these cells that are cancers that can jump, then it becomes a very different thought process. So back to your comment about margins. Standard margins, if we're just going to do a standard excision on a lower type of risk type of skin cancer, let's say like on the back, the standard margin is 4 to 6 millimeters to remove it all around it.
And
So
a
basically,
pencil eraser is 6 millimeters, just to give you, audience members perspective on how large or small that is.
and the processing for that for a standard excision, we do what's called bread loafing. And essentially, if you can imagine a cancer, and think about it like a loaf of bread, we cut it in little sections and we look and see if each in those sections, if the cancer cells are spreading to the edge. And that, because it's representative sections, essentially doesn't give a complete look at it. And what we do is we estimate, well, if there's nothing in those sections, knowing that we took the appropriate margins, we basically could say for an excision, we have a 97 to 99% likelihood that we're outside of where the cancer, that contiguous growth is. Now, that 4 to 6 millimeter margin is actually based on most surgical recommendations. So let's take the Mohs surgical procedure that Krista was talking about. Essentially, you can imagine a bowl. And let's think about the cancer inside the bowl. And what I'm doing as a Mohs surgeon is I'm cutting that bowl out, and then I'm mounting it on a slide, and I'm looking all around the edge, which is very different than bread loafing sections. And typically when we do Mohs surgery, we take a 1 to 2 millimeter margin. Most of the time, it's a 2 millimeter margin. And statistically speaking, we're going to find a positive margin in one of the directions or multiple of the directions, and it typically takes 2 cuts to remove it. So if you think about it, it's a 2 millimeter margin that we start with, and the likelihood is if we have a cancer at the edge, we take an additional 2 millimeters around that, and statistically speaking, it usually takes 2 times to remove that on average. That's where we get our 4 millimeter margins for the standard excision when we do it on the back. But let's think about the face. If I can do a narrower margin only in an area and knowing that half the time that 2 millimeter margin will be enough, that's way better than taking a 4 to 6 millimeter margin on the tip of the nose compared to what we would do on the back.
And I'm just trying to process all that you said. A couple key points, which I think are fundamental to the whole discussion. It's really what I think for many people, what I hear, the feedback I receive from patients is this was a lot bigger than I ever thought. And your explanation just a number of sentences ago describes why. Because as you are finding that some of these cancers, as you described, spread outward rather than downward, that's a lot of skin that you're removing. So the area, whether it's an excision or it's Mohs, these little skin cancers can be very tricky. And even though it may be just a tiny little dot, what's happening underneath the skin is really what's going to dictate the treatment. That's an incredibly challenging concept for a lot of people to understand because they go in for this tiny little red spot on their face and they come out with a huge hole in their face. And then you have to talk about reconstruction. So I think for many people, and I may hopefully some audience members may want to submit questions or comments, but for many people, this is what is devastating to them, where they think they're going in for something and a little something, it's just a little skin cancer, and they come out with these huge or unexpectedly large areas. And then they have to look in the mirror. And then they have to explain to people, family, friends, why they have this big bandage on their face or their head and then I know I would be thinking, what is this going to look like? And looking in the mirror, if the skin cancer is under their, on their scalp, does hair have to be shaved? There's so much that goes into it. And I think we take much of this for granted. Do you cut through eyebrows? Will people lose their eyelashes if it's on their eyelid? All of those types of things from a patient perspective, it's really hard.
Yeah, I totally agree. And every time that I meet with a patient, I will draw out the diagrams. I'll show you how we go deep. And depending on what the roots, and I really like to think about it from the root system, depends on what the roots are doing. Now, I totally agree with you. Sometimes it looks like this tiny little spot,
Mm.
and I've now ended up taking a silver dollar size hole off of somebody's face. And it can be very devastating. And, it comes down to how much laxity their skin has, how much wrinkles they already have, and how much we can hide things. But then I also have two lasers that I always talk about when we're all said and done. The likelihood is we'll construct this, it'll look overwhelming to you. It doesn't matter how small or big, you're gonna think you look like Frankenstein. But give me 3 months. The first month, most of the time, you're gonna be okay with it. By 3 months is when we really judge it. And the vast majority of times, as you've invested in healing and really taking it easy for the first couple of weeks, at 3 months is when we start thinking about, okay, is there something more that we need to do to reverse some of the redness? Can we blend the scar? And then at that point, also back to my original statements of thinking about prevention, because I've set them up. There's so many things that we could do for prevention that I could actually use for getting rid of precancer spots, but also it also remodels some of your skin to hide some of these things too. So, and if I'm doing my job right, I'm not only trying to prevent you from getting skin cancer. When you do get it, I'm removing it. But more importantly, I can prevent it and also keep you looking young at the same time with the same types of things that destroy cancer or precancer cells.
I love how you describe what you do, and I think you're unique. I know you're unique, but I love how you describe not only are you addressing somebody's immediate cancer problem that they have, but you're also thinking about prevention at the same time. Just talk a little bit about what you mean, because somebody's dealing with the skin cancer. So, what are you preventing? I think that's also a challenging concept for many people.
Yeah. Back to the comment that I made earlier about thinking about this as a chronic disease. And it's different than other cancerous processes. And the vast majority of times in some of these cancerous processes, you can cut it out, you can follow up with radiation, and then you're done. Versus this, thinking about the skin as this larger organ system, right? And I like to think about it as weeds. And if you have one large weed that's growing here that I have to cut out, the likelihood is you have a bunch of tiny little weeds all over. Now there's all these different therapies that we can do to deweed the garden. However, if you've ever tried to deweed a real garden, you know you never get rid of all the weeds. And we'll have to deweed periodically. And then maybe we could just touch base on just a couple of the different therapies. And there's everything from topical creams to special lights to even certain lasers. And much of this, once again, from the field cancerization concept, thinking about your skin like a garden, there's different recommendations based on the guidelines that show data that says these are the better things to use, or this is the better approach to use it in this fashion to get to the place that you want to be. So, and also there's also systemic things that you can do. So pills that you could take. And one of the most simple these days for squamous cell carcinomas in particular, niacinamide, vitamin B3, B as in boy, 500 milligrams twice a day has been shown to decrease risk for skin cancer over time. So it's one of the things I always hit. We've probably, if you've talked about this before, I apologize, but essentially what it's doing is it's replenishing the energy to the body's immune system through what's called the NADPH system, but thinking about it as fuel for the immune system so it works more effectively and longer. And then so there's that simple thing, there's sun protection, and then there's topical creams. And there's two flavors that we usually think about. One flavor is a cream that increases your body's immune response, and one cream is one that slows down the growth of bad cells. And these are two different approaches that you can use anywhere from 1 to 6 weeks, depending amount of damage. But what it does is it basically causes a significant inflammatory immune response to try to kill off the precancers, once again, trying to deweed it. And then there's a special light that you could use called the blue light or photodynamic therapy, where you basically use this special medicine called aminolevulonic acid, which basically is a type of medicine that's or a compound that's found in our own red blood cells. And we put it on your skin, it preferentially absorbs into bad cells, and then we let it absorb for anywhere from 30 minutes to 3 hours. Then we put it under this special blue light or red light from anywhere from 10 to 16 minutes, and it photoactivates the medicine like a smart bomb going after bad cells. And I bring all of that up from prevention, but even some of these superficial cancers in areas that are not high risk, we can also try these modalities first before surgery, especially in the setting if there's lots of weeds all over. So you have diffuse field cancerization, you have a isolated squamous cell carcinoma on your cheek, but you have all these other spots around it. Sometimes what I'll say is, oh, let's pause. Let's try to deweed the garden as best we can with some of these other things, trying to minimize the size of our surgery by getting rid of the surrounding weeds. So then we can focus in on what actually needs to have surgery and hopefully then end up with a smaller cancer, a smaller scar, a smaller reconstruction, and then smaller scar. So your question was great of how do we prevent it? And sometimes we integrate that prevention into the surgical pre-op process so that we can make everything more effective.
Yeah, that's intense. And that is having a good relationship with your dermatology provider. And that's where I was saying unique, because I don't think everybody does have these discussions in a relationship. Basically, if you have skin damage, you really need a relationship with your dermatology provider so that you can be thinking globally about how you're going to manage the skin as a whole. If it's okay with you, I want to switch gears and I want to just ask you about some practical aspects specific to scars, because I know that that's an issue for many folks. Can you talk a little bit about like the immediate time frame after surgery, and then looking, like you said, 3 months is really when you reassess. What can somebody do, or what can be done in the immediate period to improve the appearance of a scar? There's so much out there for products, scar, all sorts of scar treatments. Do they work? Do you recommend them? What are kind of the best approaches?
Yeah, great question. A lot of it has to deal with what type of reconstruction was used. But let's assume that we had sewn or sutured together a closure, and we're thinking about a scar line and trying to improve the way that that looks. Almost always my recommendation is first what they can do to invest in their own healing. I always recommend the first 2 weeks after a surgical procedure, even if it's small, I want the first 2 weeks to be an investment in their healing, as resting as much as they can. So if it's on a leg, they're going to be elevating their leg. If it's on the head, they're basically laying down as much as they can and icing constantly. And I usually recommend ice 20 minutes of every hour while you're awake. The day of plus on the day after. The bandages that you use, I usually recommend keeping the wound moist, because if you can think about how the skin cells migrate across, when it crusts up, it's literally a wall that the skin cells have to fight through. If it's moist, it's easier for the skin cells to migrate across a moist environment. So we always recommend some type of moisture. We usually recommend Vaseline, or we recommend Aquaphor. Now, we don't typically recommend topical antibiotics because several of the topical antibiotics out there have won contact allergen of the year. And what we actually find is in a setting of a clean surgical procedure, there's usually a higher likelihood of developing an allergy and a rash to the antibiotic than of the risk of actually having an infection. And then usually what happens is when they get the inflammatory allergic reaction, then they get a secondary superimposed infection on the allergic reaction. So it actually is this weird paradoxical effect. So Vaseline covering it, I usually recommend, depending on the stitches that we use, sometimes we'll just use dissolvable if it's, and we take, or we use stitches you have to take out. Usually you take out stitches in about 7 days or so, but usually the Vaseline and bandage regimen, you change your bandages daily for about 10 to 14 days, depending on how big the wound is. And that takes you to the 2 weeks where you're really investing in your healing and your relaxing. In terms of the topical things that you could put on, there are several different things out there that have some slight improvement of scars. Data is relatively questionable, but usually what I say, Krista, if you've had experience with one of the products and it actually really worked well for you, I'm not going to disagree with that. That being said, most of the data shows of the standard wound dressings of Vaseline, Aquaphor, covering it is typically all you need. And even once you stop doing the dressing, just standard Vaseline and Aquaphor in that area is good.
And I
Typically,
know vitamin E is always, brought up, putting
yeah,
vitamin E on a scar months down, a couple months after surgery. Is that something that really works?
there's the products of Moderna is one of the things they talked about, vitamin E, vitamin A. In the end, it's simply because you created a moisture barrier. I won't disagree that there might be some healing properties in the vitamin E, but we just haven't really said, statistically speaking, against Vaseline or Aquaphor, did it really show a significant difference, or was it just truly the fact that you kept moisture on there and covered it? And we think it actually leans towards that. And on top of that, some of these other products, whether it be quote unquote natural or not, they cause a lot of contact dermatitis, is just like the topical antibiotics.
And a contact dermatitis is generally a rash or irritation at the site you're applying something, or you've come in contact with it. That's the term, contact dermatitis. So we're getting to the end of our time, and I'm a little sad because I did want to talk about another topic, and that was, and I know we won't have time to do that now because you've talked about such great things tonight, but what what are the alternatives to surgery? And maybe I'll just leave that as an open-ended question, but many patients say, I can't do another surgery. I have had so many. What else can I do? Is it fair to ask you, Dr. Wisco, in 1 minute's time, truly, could you answer that question?
In 1 minute, probably not, but I can give a general statement. In the end, once again, we go back to the guidelines and what do they recommend, and then we think about what's best for the patient, right? And so from that perspective, depending on your stage of life, right? So if your life expectancy is relatively low and we're doing something like radiation for a less aggressive tumor, and our goal really isn't necessarily cure, it's more control, I think that's fine from the perspective that it's unlikely to harm you. But we see these recurrences from radiation anywhere from 10 to 20 years down the road. And one of the most common things we run
Mm.
into is more basal cells and more squamous cells. And so I feel like a lot of times it's a temporizing measure. That being said, can it be effective? Absolutely. But what is our end goal? If you're a younger person and you want to get rid of a small basal cell and you use a procedure that potentially induces more basal cells 20 years down the road, now my surgery is huge 20 years down the road. And we've run into these patients like, oh, I just tried this superficial radiation. It looked great at the time, but looking great. And once again, we track tumors at 1/1000th of a millimeter is very different from what we see with our eye and what we see underneath a microscope. And most of the time that when we do have recurrences, if they do, they don't always happen. But when they do, they're overwhelmingly bad. And then now the cancer is much larger. And we could have taken care of it easily with a smaller procedure and followed that with some of the preventative things that I had talked about.
You did it. You did it in a minute. And that was incredibly helpful and incredibly informative and pulled together that way. It makes perfect sense. And I think probably what happens is that many of the providers are skipping that piece of information when they say we don't recommend another procedure. This is why we recommend surgery. So I thank you for that. I thank you for all of your wealth of information tonight, Dr. Oliver Wisco. Thank you for joining me, and thank you to the audience. For more information, please refer to our website at aimatskincancer.com. And I wish you a wonderful evening or afternoon wherever you are in the US. Thanks for joining us.